everybody, in this video I'm going to make acute myeloid leukemia very easy and very digestible for your USMLE exams. So when we think about leukemias, they can be very confusing. Oftentimes students are getting mixed up with concepts, and so I think the best thing that you can do for yourself is to really kind of simplify everything. So simplify all of the ways that you think about all of the different parts of the disease. So first thing that is important to understand is that when you see the word acute, you need to know that that is not associated with the time frame of the disease, but rather it's associated with the types of cells that are going to be seen with this disease process. So when it says acute, that means more that you're going to be seeing very immature cells in terms of hematopoiesis, and these cells are going to be called blast cells. So these are immature precursors, and they have a distinct morphology that separates them out from more mature cells. And so the number of these cells has to be usually greater than 20% in the bone marrow biopsy to account for a diagnosis of acute. The next thing in acute myeloid leukemia is, of course, the word myeloid. Now this also gets very confusing because the word myeloid just seems really random. There's not really that much emphasis on hematopoiesis in medical school. So what you really need to know is that myeloid just means all of the white cells that are not lymphocytes. So anything that is a white blood cell but not a lymphocyte. So that's going to include neutrophils, eosinophils, basophils, monocytes, and megakaryocytes. So basically the granulated cells, as well as your platelet precursors and monocytes, of course, which also technically have granules. So all of these cells are going to be considered your myeloid cells. And then the last thing you need to be aware of is the term leukemia. So this is different from lymphoma because it means in the bone marrow. And usually it's seen in the bloodstream as well, whereas lymphomas are going to involve the lymph node itself. So there are many classifications of AML, and usually at the medical school level it's not all that important to be aware of these, but you should be aware of clinical symptoms, and pancytopenia is usually a big warning sign for oncologists that they might have to work this disease up further. So if you see a patient with fatigue due to anemia, bleeding due to thrombocytopenia or infection due to leukopenia, then you want to be thinking, does this patient potentially have pancytopenia, and does that need to be worked up for some sort of leukemia? So again, we have the word acute, which was referring to our blast cells, myeloid, which is referring to all of our white cells except for lymphocytes, and leukemia, which is referring to the location of the cancer, which would be in the bone marrow and peripheral bloodstream. So the two ones that I'll go over today are going to be AML in general, and what the kind of markers that you have to be aware of, as well as the key morphological signs that are often associated with tests, not always associated with real life, but associated with the test, so very high yield to know. First thing you need to know is that AMLs are going to be positive for MPO, which is a cytoplasmic marker. And we have these things called hour rods that can be seen in these blast cells. And you'll probably remember the hour rod. It's that weird, funky looking pink type of rod seen in the cytoplasm. And these are actually MPO aggregates, so that's how you can kind of keep it together. And so you can also remember that myeloid, or AML, has an M in it, and then of course MPO has an M in it. So that can be how you remember those two associations. The next high yield subclassification that you should be aware of for boards is going to be APML, and this is acute promyelocytic leukemia. And this is pretty important because if you treat it quickly, then it is reversible, and it is associated, high yield to note, with a translocation of 15-17, and treatment is going to be ATRA. So I think that stands for all trans retinoic acid. So that's all you really need to know at the very basic level for acute myeloid leukemia. I hope that helps demystify the disorder a little bit more. Don't get bogged down in the details here. This should be enough for your board exams. If you have any questions, feel free to let me know. If not, have a great day, and I will see you soon. Bye.